We are going, and I'm going to hand the microphone to the man to my right, Bruce Seawick.
Thank you very much, Jared. Appreciate working with you and Cheryl to expand people's consciousness, and that's a metaphor. Um, I represent the Chicago Consciousness Cafe, which got its start in Chicago at some collectives, and we've kind of moved to this virtual suburban location, both kind of a hybrid, thanks to the expertise of Jared and Annette, who is in the background there. I want to introduce Dr. Geoff Bathje, who is a licensed psychologist, professor of counseling, researcher, and advocate. His clinical work focuses primarily on substance use and addiction, multicultural issues, trauma, mood disorders, and the use of mindfulness meditation and mind-body connection in therapy. He has published research on stigma, cultural competence, substance use and harm reduction, and the medicinal use of psychedelics. He has additional interests in community psychology and the ways community, culture, and context can support or inhibit individuals. He takes an intersectional view of social issues and has engaged in community organizing, activism, and policy reform on issues related to economic justice, racial justice, mental health justice, harm reduction, and ending the war on drugs, which is a lot. And we thank you for that, brother. And I'll turn it over to you.
Oh man, it's a lot of stuff. All right. Do you want to, we don't have too big of a group. Do you want to do introductions quick, just to say hi, say your name, sort of thing?
Sure, let's do it. We got the microphone for other in-person folks.
I think I recognize some people, but it's small.
Yeah, it's small but mighty.
Hey, Geoff, John Neal.
Thought so, yeah. All right.
I'm Jeffrey Quality Brooks. I'm an artist and curious on the topic.
Cool.
Jamie Foster. I'm a student of Bruce's and an artist.
Hi, Geoff. It's good to see you. It's Karen Seawick.
Hey, Karen.
I am Annette Villarreal, and I am the Kane County coordinator for the Recovery Oriented System of Care.
All right.
How about our folks online if they want to say hi real quick?
Hi, my name's Alyssa Weinrich. I'm the president and co-founder of Psychedelic STL. It's our nonprofit down in St. Louis, your sister/rival city, depending on which sports teams you like. And we had hosted Bruce in August, so it's wonderful to be a part of this. Thank you so much for the invitation.
I don't like the Cubs, who are good.
Excuse me. Hi, I'm Stacy Hunt. Also coming to you from St. Louis. I spent 20 years in the Air Force Reserve and have used ketamine for a variety of things starting in 2022, and it has completely changed my mental health and really, really helped me and given me a good result.
Great. Thank you.
Thanks, Stacy. Do we have one or two more, it looks like? If
Brian?
not, he's with us in spirit, I bet.
All right.
So thanks,
Cool,
Geoff.
right. Yeah, happy to jump in. We got like a weird screen going on here. I don't know if, oh, I see it's just who's pinned. All right, all good. And let's see, do I have ability to share? It looks like I do. Cool. All right, so before I throw anything up on the screen, feel free to like jump in and interrupt with questions and things. Some of you might have different familiarity with ketamine or with ketamine assisted therapy, so happy to respond to things that are of interest too. I do have a presentation I can draw from though as well. First thing I'll mention is sometimes there's a debate about whether ketamine should be called a psychedelic or not, and I think that comes down to people who are more interested in the molecule, and so they want to define what's a psychedelic by the molecule, and there are people who are more interested in the phenomenology of the experience, and so they're more concerned with a particular type of experience and what that includes. And so I very strongly consider ketamine psychedelic because it seems to very reliably create psychedelic experiences, and I'm not as interested in the fact that it's not hitting the particular serotonin receptor that we tend to use to define psychedelic. So if you're interested in the phenomenology of it, then I tend to think there are drugs that can be psychedelic that are used in non-psychedelic ways, like microdosing, and there are drugs that aren't kind of classically defined as psychedelics by their molecular structure that very much produce psychedelic experience. And for that matter, I'm interested in other things like holotropic breath work or flotation tanks or these other things that produce these, can pretty reliably produce non-ordinary states of consciousness. And so that's how I'll kind of sidestep that question, even though ketamine is technically classified as a dissociative anesthetic, which it is at high enough doses, but those aren't the doses you use if you want to use it as a psychedelic therapy tool. Cool. Any questions about that? Yeah, feel free to jump in anytime if you have questions. So. Okay, can y'all see that? Including at the Apothecary, you guys got a good enough screen, you can see that? Yeah, great. Let me full screen this. Okay. All right, so it's been around since the 1970s. The scientist who developed ketamine, whose name I don't know off the top of my head, dissociative anesthetic was the term proposed by his spouse, which has stuck. And the reason they call it that and why it was of interest in 1970 was they were looking for an anesthetic in the Vietnam War that could be used on the battlefield where somebody could not be unconscious, but rather dissociative. So they would be kind of separated a bit from their body. And so if there's injuries, pain, it will dissociate you from that a bit. But and so it's kind of an unfortunate term, though, because we tend to think of dissociative a lot nowadays in relation to trauma. And I think because ketamine is called a dissociative anesthetic, when I first started working with it like 9 years ago, the consensus seemed to be that this is not the right substance to use for people with trauma because they already experienced dissociation without anyone really asking how similar are those types of dissociation. Turns out not very similar after many years of asking people who have trauma histories who experience dissociation. Is the ketamine dissociation similar to the dissociation you normally would experience when there's some trauma triggers? And almost always the answer was no. It's very different. Like you're still cognitively very present. You're just less aware of your body. So much in the way that like we don't call Novocaine a dissociative, even though it's doing a similar dissociation from the body at a high dose. Right, so it's just making you a little bit numb and less aware of the body. But then this is used in therapy. It's not nearly as extreme as like a Novocaine kind of thing. You can pretty easily sense the body just by some movement or touch. But if you hold somebody's hand the whole time and they're not moving, they'll start to feel a bit like a brick or something, right? So. But movement or touch sensation you can still perceive that easily on therapeutic doses of ketamine. So we work with the generic ketamine, and that's most of what's being prescribed, even though ketamine has these two molecules to it. They are considered left-hand and a right-hand molecule, and you can see them there in the picture. So kind of like your hands, they're mirrors of each other, but they're not overlapping. Right. And so S-ketamine, which you might be familiar with, was branded as Spravato, is the S isomer. There's another company working on the R isomer, R-ketamine. And then the generic is a mixture of the two. It's called the racemic, and it's a mix of the right and the left. So basically, for the sake of being able to patent something and sell it, you filter it. These two companies are filtering out one or the other of the two molecules and giving you one of them, and they can patent the process to isolate that one molecule. But they still can't patent the molecule because it's been generic for a long time. It's been around since 1970. So you might ask the question, if S-ketamine has therapeutic benefit and seemingly R-ketamine has therapeutic benefit, wouldn't the generic that has both be better? And we know in head-to-head studies, racemic performs better than S-ketamine, than Spravato. And I assume the same will probably be true of our ketamine. So yeah, seems like you want both if each one has therapeutic potential, right? I won't go into all of this, but it's working on a different system. It's working on NMDA receptors as opposed to serotonin, which is much of the action of psychedelics. So that's really interesting too, right? That just even the fact that that this drug has a totally different pathway than MDMA or ibogaine or ayahuasca or LSD or psilocybin. 5-MeO-DMT, different pathway than all of those, but still disrupts the brain in a way that produces a coherent psychedelic experience. I find that interesting that all these drugs have even those aren't all doing the same things. They do different things neurochemically and seem to all have benefit and seem to all produce these psychedelic experiences still. It's not obvious, right? You'd think if you just disrupt the brain, like if you disrupt your TV signal, maybe you get static, you don't get anything coherent. So there are different ways you can administer it. Not right now, a lot of the oral lozenge or rapid dissolve tablet prescription is going on for like home use. You can inject in a number of ways. We do those all in our office. We'll do intravenous, intermuscular. I did work at a clinic before we opened our clinic for a little while that did intranasal, so nasal spray. There's another route of injection here that's also pretty close to 100% bioavailable called subcutaneous. So it's under the skin, but not in the muscle. And really, it's just like I doubt that any of those is more effective than the other, of the ways of injecting it. I think they're all pretty similar, but experientially, they're a little bit different. So as you might imagine, intravenous is that slow drip. So it's kind of a slow buildup and it ends pretty quickly for most people at the end. An intramuscular shot, you'll process that very similar to how you process it. Something that you take orally, which is that it's going to be stronger at the beginning and kind of taper off gradually, have a higher peak because you get more of it processed on the front end all at once. And then the subcutaneous, the under the skin injection, is kind of in between. So if kind of the trajectory I just described there, it'd be somewhere in between. So it'd be kind of like a slow hill, so not as high of a peak, and takes a little bit longer to reach that peak. So those are different routes. And then, depending on where you are in the US, like an infusion could be anywhere from $300 to $700. For generic ketamine, it's not coverable by insurance. So this is an unfortunate thing about off-label usage is if you're kind of in the same ballpark of why this drug was approved in the first place, no problem, off-label use will get covered. So probably half of psychiatry is off-label prescribing. So they might give somebody an antipsychotic because it makes them drowsy and they prescribe it as something to help with sleep, for example, or prescribing antidepressants for anxiety. That's not what they were approved for, but it's in the same ballpark, right? It's a psychiatric drug used for a psychiatric reason. And so it's reimbursable, but because this was approved as an anesthetic, that's not close enough that the insurers really want to reimburse it for mental health uses.
Hey, Geoff, can I ask a question real quick?
Yeah, please go ahead.
So I had a question about the different routes of administration. So how do those usually get chosen? I mean, obviously it's depending on is that decisions made in agency with the client? Or is it
so person by person with the client? Yep.
Okay.
I definitely have a little bit of a preference not to do an IV unless there's a reason for it. So unless the person's just maybe they're more familiar with that, they've done it elsewhere, or they're more comfortable with it. But I as somebody who does I incorporate some somatic work, it's like movement work, and so I want the person to be free to move, and it's a little bit harder if you're tied to a line. It's just a little bit more medical feeling as well. But it's fine, not for effectiveness reasons, but if somebody if somebody experiences a lot of dysregulation or intensity, then the IV can be a nice option because it is so gradual. It just kind of sneak up on you a little bit rather than feeling scary.
Looks like we got another question.
Hi, I have a question about the pharmacology. The isolates, there's two that are active in
Mhm.
use. What are they isolated from? Is it a plant? Is it a
No,
synthetic
no,
compound?
ketamine is synthetic. Yep.
100% synthetic, never
Yep.
derived from anything
It is not
plant
plant derived. No. Yep.
ever.
No.
Okay.
I don't know for certain that there's no way to do that, but I'm not aware of anyone doing that. And because it's a pharmaceutical, I mean, those are generally not derived from plants. Much of any pharmaceutical. You know, we could go into the why of that, but yeah, it's some things could be obviously that are not.
Thank you.
All right, thank you. Any other questions on that first couple bit? Okay, cool. Back over to you.
Sure. Yeah. Okay. And so, so still to this day, most clinics do not incorporate a therapy component, and I'll differentiate between those, between like a purely biomedical application of ketamine and a psychotherapeutic application of ketamine. But so yeah, when I started, there were only a couple of clinics doing it. I didn't have so many options to like take my clients to, but tons of them now, and then tons of kind of like online companies that prescribing that kind of started with some of the loosening of prescription rules during the pandemic. And so, you know, so the psychiatrists eventually did issue a consensus statement on how they thought ketamine should be used. Those are non-binding. But the standard protocol in infusion clinics is to do 6 over 2 weeks. And there wasn't really any rationale to that other than that was like the ECT, electroconvulsive therapy schedule in the clinic where they were testing that model, that it was available 3 days a week. So, and that's how ECT was administered. So they followed that schedule. And so what we find with therapy is that's too frequent. So we actually only ask people to do half that, to kind of commit to doing 3 infusions, and we don't like to do them more than once a week, because it doesn't give people long enough to really make use of that and integrate that. Like you're just, you know, pressing the lever of the biological effects, the biochemical effects, rather than making use of the psychology of the psychedelic experience. So find that if you slow down a little bit and are more reflective with it, you don't need as frequent or as many ketamine sessions. But that's going to vary a lot per person. So kind of 3 seems to be the minimum where most people can retain the benefits. But people certainly might do more than that as well. It seems like the more complex the trauma history, the more likely we need to kind of take it slow and maybe spread out more sessions over a longer period of time. So it's supporting their therapy. Okay. So I did want to compare, there's some research comparing ketamine to S-ketamine that came out pretty quickly after Spravato was approved by the FDA. And so Spravato is reimbursable by FDA. It's a nasal spray, if you're not familiar. And that's the S isomer, so one of the 2 isomers. And so, yeah, in a comparison of ketamine, and this is without therapy, versus Spravato, also without therapy, they looked at 24 trials, 1,800 plus participants, and these are risk ratios or odd ratios that says like how likely is somebody to go into remission in the treatment group versus the placebo group. And so 3.7 would mean the person who got the drug is 3.7 times more likely to get remission from their depression in the study versus somebody in a placebo group. And so this was generic ketamine 3.7 and Spravato was 1.47, so 1.5 times as likely. So you can see that effect sizes, overall response 3.01 to 1.38. So the effect sizes are almost, you know, they're more than double for generic ketamine versus Spravato. Also lower dropout rates in those trials. And so, yeah, so that's interesting, is that kind of endorsement of generic ketamine actually over the approved version. And so one of the other big questions that comes up, not just with ketamine, but with psychedelics in general when they're used for therapy is, could you have a psychedelic without the psychedelic effects, right? Or how important are the psychedelic effects to the outcomes. And so turns out they do look to be important, that those things that get treated as side effects by the FDA, right? Like having visual distortions, heightened sensory perception, transcendence, these are all side effects as far as the FDA is concerned. But does seem that over several studies that the psychedelic effects matter, that so people that that score higher in saying that they had more of a mystical type effects from ketamine have better outcomes. Those who have more what they call psychotomimetic symptoms, that's like an old term that where people assume that psychedelics were mimicking the effects of psychosis. So that would be like like closed eyed visuals or enhanced sound, that sort of thing, also correlate with good outcomes. And then let me see, which one was this one? Oh, that the dissociative side effect predicted better outcomes. So getting people above that dissociative threshold correlates with better outcomes as well. So it says that, and then lastly here, let me see, this one was also, this was also looking at dissociative effects, and then mystical experience or near-death experience, scale that they used in this study, decreased cocaine use and craving in that study. So in every study, it says that the psychedelic effects seem to be the therapeutic effects, not just side effects, and that a higher dose, you're more likely to get those effects. So it's not purely just a higher dose is better, more is better type of thing, but there's some truth to that for sure.
I did have a question about that. So as I leaned over to Bruce to whisper, I don't like dissociatives, just because I've had bad experiences in the past. When you talk about the dissociative threshold and like pushing past it, can you explain that one to me?
Yeah, I'd be curious too what what your,
or if anyone else would like to point out.
Too, but yeah. So I would say like it's gradual, right? So like everything else, I mean, even the visuals, right? You go from like having ideas to like vivid imagination to actually seeing something, right? So most things are on a continuum, and I think the association is too. Usually that where we're dosing people, it's more like imagine being like I give the analogy of like being in a warm bath, and if you don't move for a while, you kind of lose track where your body is, because it's the same temperature as the water. But as soon as you tap or something, or move your hand, you know exactly where your body is. And ketamine is pretty similar at the, if you're just getting over that dose. And usually where you're getting into like the harder dissociation, people also don't remember it very well. And so then it becomes less useful psychologically, just because they don't remember the experience. So we're usually not going for like a strong, like anesthetic dissociation, but something more mild.
Got it. Any other questions for that dissociative part we just went over, or anything in the slides? If you do, feel free to come off mute or just raise your hand and we'll make sure to stop. Oh, we do have one. We'll get the mic over there.
I have very limited experience with this, but I remember meeting someone that was a friend of my son's, and he was on ketamine all the time and always checked out, and he was abusing it. So my question is, and if you're covering this later, just tell me and I'll be quiet. But I'm wondering, what is the abuse potential here with folks? And do you see that more happening where there's not a therapy component? And is it one of the more commonly abused substances, or not really? Or what's the landscape on addiction around ketamine?
Yeah, sure. So I can't help but do some advocacy as a harm reductionist here. So
yeah, let's do it.
For sure, yes, there is such thing as ketamine use disorder, and I'll talk about some of what I see as some of the risks and protective things there. I try not to use the word like substance abuse. I know it's even still in our agencies. We have agents like substance abuse agencies at the state and federal level, right? But our last diagnostic manual revision, I don't know when it was, 2013 or something, 12 years ago, they kind of remove that for stigma reasons. And so so I always prefer to just kind of go with substance use disorder. Even addiction is okay, but just kind of like a basic point I want to advocate for there. But yes, that it definitely is possible. And with most things, I think you know, the frequency of use and how you're using, like particularly like more escapist type of use, is more reinforcing, right? And so the more reinforcement, it's like addiction is learning. Ultimately, you're learning an association between this drug has this effect that I like, whatever it is. It either takes you away from something uncomfortable or gives you a pleasant effect, right? And so addiction, think of it as like it's learning fundamentally, right? You're training your brain. And so the more reinforcement, right, the more pleasant and kind of or like escapist experiences, and the more frequently have those, the greater the risk, and then kind of like your personal risk factors for that play into it as well. But ketamine doesn't seem to, it's not a particularly dangerous drug compared to a lot of others. It definitely has some potential there. Definitely hearing about ketamine use disorder, especially with the frequent at-home lozenge use. I don't worry about it much when we're using it in office, higher dose to face therapeutic things that are often pretty uncomfortable. So it's if it is enjoyable, it's usually a mix. It's like challenging and enjoyable, right? And so I think it's not as reinforcing that way. Like you don't learn like this is a good way to like. People often say that like people do this for fun, like after doing it for therapy, right? And you see the same in like the MDMA trials where that could also, you could have a use disorder with MDMA as well. And so I do worry about like the frequent at-home dosing, and so even like people who've like come through and done our process where it's very integrated with therapy and very intentional. So if they then like later get a at-home lozenge prescription somewhere from one of these companies that's doing it online, it's really difficult, like if you're doing it 3 times a week, to maintain the intentionality and the structure around it, right? Like it's just hard. It's even though it's like a 2-hour appointment when somebody comes in for ketamine, it ends up really being like a most of the day thing, because you don't want to be working right up until you come in, and you're definitely not working afterwards. I hope you don't have to. So I mean that time commitment to really make it intentional is very difficult to do the more frequent you're doing it, right? So.
I have another question too, if you don't mind. Kind of piggybacking off the frequency, but you also had mentioned like a certain amount of times, depending on, the route of administration or however the appointment setups were. But is this meant to be like a let's get you through this trauma? Like we'll work with the ketamine over a certain period of time, but ultimately like we need to like not have this be a forever thing, where like you're coming back, continuously. Is that the goal of a treatment like this?
Yeah, it's always our goal is to help the person resolve the things that they're coming in for. And doesn't mean like once they've had a good experience with it, doesn't mean like if there's some other things, like they might come back and decide like, oh, this was helpful for this, maybe it can be helpful for that. And so might see somebody a year later, 2 years later or something. In the infusion clinics, when I was going with the ones that aren't providing therapy with clients, they would kind of, their standard estimate was like 40% of their patients were going on like a maintenance protocol. So they'd come in, monthly or whatever the frequency would be. Ours has been way lower than that. Certainly some people do continue with it. Like I think like particularly with like really complex trauma cases, that it might take quite a while to work through that. I mean, it might with therapy too, right? You might never work through it. It might take many years to work through it. So no different with ketamine. It's a useful tool that can really be helpful, but yeah, for sure. We have some people that do, whatever frequency, maybe it's quarterly, maybe it's monthly. If they're still seeing benefit of it, or if they really have a crash, like if they go too long without it. But I would say that's probably more like, like 10-15%. And pretty reliably, it's people with PTSD and complex like PTSD, like childhood stuff too. So,
yeah. Okay. We had another question too. Yeah.
So I have a couple questions. One, as we talk about maintenance, what is the probability of building a tolerance to this. And then the other one is, it sounds like you're working with like either talk therapy or moving people around like while they're doing their treatment. And I've been doing S for a couple months now, and there's no consideration for set and setting at all. And I'm kind of curious if it would be more beneficial to me to be in some place where there's, not construction out the window and lights turning on and off and people marching through.
Or, blaring overhead lights in a medical chair or something.
Oh, yeah.
I think so. I mean, like same way you'd want to do mushrooms, right? Like you get a sense pretty quickly that like this should be warmer and cozier and not blinding brightness and good music and all that. And so, like we have couches in our room. So the stereotype of what people used to think therapy was, right? Like lay down on the couch and actually want to do that with this one. But so yeah, I think it is beneficial though and not always are people like very talkative during, but even just like to be able to say some things out loud and have somebody there who's your scribe who can take notes or who can, give you some guidance or help you reground or respond to you if you have a question or a concern or something. It tends to let people go a lot deeper in the experience when they have that support there.
Great question.
Was there a follow-up too? Were you
on the question of tolerance?
Yeah. Oh yeah.
Do people build a tolerance?
You can, and the more frequent you're doing anything, the more likely you are to build a tolerance. So in the once a week schedule, doing it a few times, no, don't really see a tolerance. But the more often people are using it, yes, you can build a tolerance.
Great question. Anybody else before we keep going? Oh yeah, we got another one.
I want to circle back, John, right quick before you go, because I forgot to mention something is on the addiction question is that ketamine, like other psychedelics, can be anti-addictive too. So that's actually an application is ketamine to treat addiction or ketamine to treat to help somebody with their depression or some other issue when they have a history of addiction. So I've worked with quite a lot of people who've been sober for a long time and have not seen it throw people back into substance use. So I do think the intentionality makes a big difference in the same way that people seem to be able to, take a pain medication when they have some chronic pain condition, and it doesn't necessarily put them at risk of, problematic substance use. So yeah. Go ahead, John.
Question in the chat too.
Oh, right.
Says, do you have comments on the recent study in the JAMA psychiatry stating ketamine was no better than placebo for depression and quality of life?
Drop the link there. I'd love to see it. I'm not positive which study you're talking about, but Brian, feel free to drop the link in there. And if it's one I'm familiar with, I'll respond to it right away. And if not, I might need to glance at it. Go ahead, John.
On the subject of addiction, how would somebody wean off of that if they're, I know a guy who's got like a 5 gram a day habit, and he's checked out. He's a ex-soldier, and he says he started it as a self-treatment for his PTSD, and it's become, abusive, and it's not a good way of life for him. And I'm trying to figure a way to, help him. What can you do for someone who's that involved? And is there a way to help them wean off, or I guess they'd have to want to?
Yeah, well, I would think if that's been the substance that they've had a problem with, maybe a different psychedelic could be helpful, because certainly there's research on using other psychedelics for addiction, right? But and this is something that you're not really supposed to do in the United States from a prescribing perspective. You're not allowed to prescribe the drug that the person's addicted to for the sake of treating the addiction, right? That's why we, some countries will do trials or even full-on programs where they prescribe heroin to people and so that they can stabilize. So they go from the chaos of seeking and not having it and being in and out of withdrawal and desperate to find it, that they'll prescribe it, and 90% of people stabilize on the drug that they have the addiction to, right? And so it doesn't work as well for every drug. Like an opiate, you could take every day, but like a stimulant you can't take continuously. So, although it's been tried there too, like prescribing, Adderall for, cocaine addiction or something. I don't think the effects have been as great for that, but I mentioned that because I've seen a few people who have like they've had recreational use of ketamine and have been concerned about it. You can, by using that drug in a different way, more intentionally, you can maybe change or expand your relationship to that drug. I had a mentee who did a basically like an integration group for PCP users, and they were so relieved to have like a place where they could come and talk about their PCP experiences openly, because some of them had like spiritual experiences, like just things they valued come out of that. And PCPs actually hit some of the same receptors that ketamine does, which is interesting. But it's very stigmatized substance. But
I was just gonna say it's one of the most stigmatized substances
yeah.
out there.
Yeah. One of my favorite studies, they were trying to see, like, based on all the stigma of PCP, right? Like, it makes people hyper, superhuman strength and incredible Hulk aggression and all that. So there was a primate study where they gave a monkey within a group of like monkeys who knew each other. They were buddies, right? Like they gave one of them PCP to see like what would that do to their social functioning. The other monkeys attacked the one on PCP because its behavior was abnormal, rather than that one being aggressive. So it's very much mirrored what humans do. I think it's we attack the person for being abnormal.
Stigmatizing, yeah, even at that level.
Yeah.
Wow.
So anyways, how did I get onto that? Using the drug in a more intentional way can change or expand your relationship to that drug potentially. Not something that's really being researched or anything, but it's an idea that I think hasn't really been explored.
All right, I'm gonna ask another ketamine newbie question. So, as somebody who has only known recreational ketamine, aka like K-holes and those types of things, I was someone that was like scared away from ketamine because of an experience in a K-hole. And I know that's like kind of slang for obviously a state you go into on ketamine. Is this similar in any way, or is K-hole something like, okay, you've taken way too much, you cannot move, you don't feel anything anymore? Yeah, like where are the levels with that?
Yeah, what did you experience? Were you kind of falling, or were you stuck? What was your experience?
I felt like I couldn't move my body at all. I almost felt like I was like paralyzed at a certain point. And then like I could see my body and like I could see it moving, but I wasn't moving it. But it was the sedative effect was the biggest one that I found. Like I just like couldn't really move.
Yep. Okay. Yeah. People might think they're dead or something based on that. Yep. Okay.
Not fun, I'll say that.
Yeah. I mean, if you're going to have that
for me anyways, yeah.
If you're going to have that experience, probably better to have it with somebody there with you who can reassure you you're okay and it's going to wear off, right? So, but we don't aim for that dosing. No, that would be a little bit high. Certainly I've had a couple of people in my 9 years of working with ketamine have that experience. More so at the infusion clinics where they often they dose people pretty high. I mean, one of the things you can do with ketamine that you wouldn't do with another psychedelic is you dose them higher to knock them out more if you don't want to deal with them interpersonally, right? And so some of the places that don't offer anything much interpersonally will just push the dose much higher, and then people don't remember it well, and they K-hole more often. And I'm not like afraid of the K-hole experience, but we also would never aim for it. But so if somebody went, everyone's going to respond differently to the dose, right? So somebody on what you think is, just a moderately high dose might K-hole where you wouldn't expect it. So just like anything else, like challenging or scary that came up in the experience, you just want to kind of support the person, reassure them. But on that one, it might be hard to tell what's going on because they're probably not doing much or asking for support. So we don't aim there just because it would be, we want people to remember the experiences and be able to do something with it. But I've also heard people say like they were able to face some fears in a space like that. But again, we're not aiming for it, but can you do okay work there? I think you can.
Right. I think that was the questions on that one. If we want to get back to anything else.
Yeah, I was trying to click on this study that got dropped in there.
Oh
but,
yeah, it did get dropped in the chat.
I'm curious. I'm not. Let me see. I'm not seeing like the name of the author on it, and the date is yesterday, so this would be fresh off the press if that's actually published. Let me see. Is it a meta-analysis? What is it? I'm gonna look at this quick just because I'm interested in it. In Ireland.
And maybe while you're doing that, if anybody else has any questions, we could line it up. Kind of, it looks like we got about 15, 20 minutes left. So yeah, got any others we can get through. Or if you just want to continue having conversations based around anything we've covered so far, we can do that. This is obviously a nice intimate group, so we can kind of take it however you'd like.
I do have one more question.
Yeah, absolutely.
My last few sessions, like about 4 hours afterwards, I had like a lot of racing heart. I don't know if it was a panic attack or if my heart was actually like having a cardiac event. I didn't go to the doctor because money. And I was wondering if there was any precedent for that, or if it's all in my mind, or if you have an opinion.
What was the event? What did you notice was happening?
In my chest, pain, trouble breathing, like right at the sternum. It's just.
Did they check vitals on you there?
They do. I'm always like right there at 150 over whatever. I'm always pretty high when I leave.
And you told them about that at the office, or?
I did tell them, and they did the following treatment, and like, I feel fine leaving, but then like maybe 4 hours afterwards, again, last night it hit me again. So I was real curious. Is there any precedent for that, or is that all in my head, or?
I mean, I never want to say it's all in your in your head, but and how do you differentiate, right? So like, what's mind body and what's mostly body and mostly in your head, right? So and I'm a psychologist, so I mean, if somebody was reporting that, I would definitely tell our prescriber to talk with them about that, and depending on what he heard, he might refer them to get it checked out. So I don't know, like, I don't want to discourage you from from looking into that for sure. Ketamine, ketamine is very safe. It's hard for me to imagine like the ketamine would cause a cardiac event, but that doesn't mean there something could be happening and that coincides with the ketamine, right? So certainly your blood pressure can change higher or lower on ketamine. So it does do some things like that. For most people, it actually relaxes them when we check their vitals. So actually usually lower at the end than at the beginning. But panic attacks could happen. I don't know if that's possibly what you're experiencing. It's hard for me to know, right? So we never want to discourage somebody from getting something checked into. Wish I could give you something better there. I'm sorry, but yeah.
I have one question about the actual like therapeutics that's coupled with it. So you obviously talked about movement. You talked about some talk therapy. Those were the two you mentioned. What are some other therapeutics that can be like coupled with it? Are those the two main ones y'all do? Are there others that are maybe emerging? Because I'm trying to imagine like myself seeing a therapist like I see a therapist, but now being in that state, and would it change the way I would talk? I haven't done it, so I don't know. So I'm just kind of curious. What do we pair with the substance?
Yeah, and this is actually one of my critiques or cautions of where we're going with pairing therapy with psychedelics. Is I think we're foreclosing a little bit prematurely around a couple of theories, and none of which were designed with a psychedelic in mind. And so maybe the therapy that's going to work best with psychedelics doesn't exist yet, and we shouldn't foreclose around theories. But certainly some of them seem congruent, right? Like mindfulness meditation that's been recognized all the way back to the 60s. That Ram Dass and Tim Leary and Ralph Metzner and all them. But certainly some things seem more compatible in different ways. you ever used a psychedelic, interesting mind-body things happen. So that's why I end up incorporating somatic stuff with psychedelics. And also because I see a lot of people with trauma histories, and so the body often gets left out of that. So paying attention to the physical experience, and the physical memory people have of trauma is not just up here. Internal family systems is one that's been pretty popular, and they've been open. The developer of that, who's in Illinois, Dick Schwartz, has been real open to having them used with psychedelics or with ketamine. So IFS has been getting popular, I think, because of that. If you're not familiar with that one, internal family systems is the idea that we have these different parts of ourselves inside that are sometimes in conflict, or sometimes do things like are trying to help us, but are holding us back in certain ways. And so the idea that, simplest version of that, it's like, I want the donut, but I want to lose some weight, right? Like different parts of me that are in conflict. And so, but there'd be more nuanced versions of that as well. So that's one. I'm training an approach called narrative therapy that I think has a lot of interesting parallels with making meaning of psychedelic experiences and getting people unstuck and seeing new perspectives. So narrative therapy is one I think would be really promising that's not really being used with psychedelics much at all. The transpersonal theories like Carl Jung or Stan Grof to address the spiritual experiences and symbolism and kind of the dreamlike nature of psychedelic experience. So that's certainly used. Acceptance and commitment therapy, which is a cognitive behavioral therapy that includes mindfulness, gets a lot of use in psychedelic space. So again, I think these all offer like different things, and they all compensate for some of what would be lacking in the more traditional models, but it's all partial. And so that's why I say, like, I don't know if the ideal therapy exists yet.
Yeah. There was, I think Alyssa dropped something in the chat. And let's see. Sorry, I haven't been able to keep track of that as much as I usually do. But yeah, so ACT has promise
The same
also.
one.
Yeah,
Same one?
Jeff nailed it. I was gonna say acceptance and commitment therapy as promised, and then also I linked that actual JAMA article instead of the news article that it was cited from, just for your reading pleasure, Jeff. If you
Yeah,
haven't
thank you.
found it.
I was trying to glance at it quickly, and the thing I couldn't tell is if it was multiple dosing or a single dose.
So it's intravenous dosing against the use of midazolam, which is
Do you know how many doses, how many sessions they did? Was it one or was it multiple?
I think it was so it's serial infusions versus their control was actually what they purport is psychoactive, which is a psychotherapeutic for depression already on the market. So I find that those studies can be a little bit biased in the sense that when we're using a traditional psychotherapy and we tell people it's a traditional psychotherapy, they're like the placebo effect actually comes into play when you give someone what they know that their doctor would give them versus something that's experimental. And so they have these expectations around experimental treatments like psychedelics or ketamine, whereas their expectation when they take a pill that their doctor says we've prescribed for 50 years, they're like, oh, well, it's made people happy for 50 years. Why not me? But this other random thing, you never know. And so I think controlled studies with psychedelics like that, when you're giving someone something that they expect to work versus something that they might have preconceived notions about, can get a little hairy. But that's my 2 cents.
And there's and so just glancing at the study quickly, yeah, thank you for that. And glancing at it quickly, I can, so that's not a ketamine assisted therapy study. It's versus ketamine. I can't tell, like, it looked like maybe they were using a single ketamine administration as the control in some cases, so single versus multiple. Probably like a disproportionate amount of the effects come from the first session. So it's not that the subsequent ones don't have value too, but that's going to skew things, especially depending on when they measure the outcome. They were using benzodiazepine as the control, which certainly also has therapeutic potential, which is going to reduce the comparison. But one thing we don't have for any psychedelic yet is a good head-to-head trial of psychedelic assisted therapy versus just the psychedelic. And I'm that probably needs to happen just so we, you know, it'd be shocking if it didn't add something, because every psychiatric drug, you get better results when you add therapy. Antidepressant, antipsychotic, benzodiazepine, like all of them work better when they're combined with therapy. So if that weren't the case with psychedelics, that'd be really interesting and shocking. But nonetheless, we need to prove it probably with a study or two just to demonstrate it. I did I worked on a meta-analysis, the first meta-analysis that combined all the data from the psychedelic clinical trials, looking at psychedelics as a therapy specifically, not just psychedelics without therapy. And we tried to look at that, like did more hours of therapy correlate with better outcomes? But the range was too narrow. It was like, you know, on the low end, it was like 6 hours of therapy, and the high end was like 12. So it's like 6 versus 12. You know, are you going to detect a difference between 6 versus 12 therapy sessions? No, not with or without a psychedelic. So we couldn't demonstrate that, but the question still remains, like, if it was a big difference, like no therapy versus, you know, a good amount of therapy, or larger gap, what would the difference be? So yeah, I'm going to look at that study more closely. I'm interested, but I'm also a little bit you know, I suspect that ketamine on its own is much less effective than ketamine assisted therapy, based on my own kind of like clinical experience doing that, and from a lot of clients who went and first did ketamine on its own and then came for ketamine assisted therapy. Like, I've just, lots of them have told me it's vastly different experience. So that's my first guess. I don't want to dismiss it, but yeah, it's there's a couple of factors at play in that study, it looks like.
I'm sitting next to Bruce, and I realize I haven't offered to let you ask a question. So I don't know if anything has come up that we want to cover with the time we have left.
I know that one of the early studies that was published was Krupitsky working with ketamine and as an antidote to alcoholism in the way of making it a terrible experience. I hope that's not something that's still out there. Is that something that kind of came and went?
What was the experience?
He
like
was
an aversive experience.
Krupitsky in Russia was using it to get alcoholics to stop using by making it, you know, by dosing them and then having them smell the alcohol and kind of associate
like an aversive thing. Huh?
Yeah, almost like almost like a psychotomimetic, you know.
Mm-hmm.
I'm just saying, I haven't read anything about that, but that was one of the early things I've read about it as a way to get the alcoholics to bottom out, which is how the psychotomimetics was looked at.
Yeah, I would hope not either, because that's, you know, definitely a failed treatment approach, right? Like abuse with alcohol, like, doesn't really work very well.
It's still out there. I've found out abuse is still out there, which is, but which means it has to work on a certain percentage of people. Yeah,
and I respect autonomy. If somebody wants to give it a shot, you know, why not?
Yeah. Yeah. We got about 3-4 minutes left. Any other I mean, this has been a great like conversation. I think we've gone in some really cool directions and in some ways that like I'm pretty like a newbie to ketamine. So this has been good for me to pick up like a lot of this stuff, but also the discussions about, you know, the therapeutics versus, you know, just the psychedelics. And I think what you said was true, which is there doesn't seem to be one great study, you know, that we can point to for some of these things.
Yeah, let me, I'll show you one last thing here that I want to just emphasize, that'll kind of like also drive the point home of kind of the whole process. And so, you know, I think that when we think about psychedelics as therapy tools, we can have a very drug-centric perspective, right? Like it's that, but we're always doing several preparation sessions with people before we ever have the medicine experience. So making sure we understand their background, their history, what they're coming in for. Not getting too narrowly constrained in a medical model that, you know, people often come in with a diagnosis in mind, but psychedelics are expensive. If you ever taken one, it's like you thought you were there to work on your anxiety, and you know, you're all over the universe and all over your history and everywhere else, right? So so making sure you have a good kind of understanding of the person, help them with how to navigate those experiences, and talked about some of the logistics of the experience. And then during the session, I think often the first hour looks very different than the second hour. Like when somebody's under the influence of ketamine, it's very non-directive. So it might have given the impression that we're doing like somatic work. That's usually afterwards, like when it's worn off, just because they're, not as present to their body. But sometimes somatic work just happens on its own, right? Like somebody might, be shaking or something, and something processing there. But during the ketamine, we're just trying to be like non-directive and supportive, and doing things like remind them of their intention, or helping them ground, or encourage them to keep going. But pretty non-directive. So it's often like inward focused, headphones on, eye mask on if they're comfortable with that. And then taking notes if they have things to say, weighing in only when you feel like it's necessary. Some people might want you to like check in with them on regular intervals if they're nervous about things, or they think they won't ask for help. And then the second hour, though, kind of the full spectrum of all all my psychotherapy training. Like, so whatever makes sense. It might be anything from reviewing that experience to like following some of the threads of things that came up, doing some somatic work, whatever makes sense for the person. And then integration, so it's a meeting again in between every ketamine session, that we don't go to another medicine session until we've had additional time on a non-ketamine day to talk further about that experience and set the next intention, which is why we don't like to do it more than once a week. Doesn't leave room for that. So, and then with integration, we'll give them some tips of like, what can they be doing at home in between sessions, based on the experience they had. And I wrote a whole article on integration that I'm happy to, I can send you by email if you want to share it with folks. But
yeah,
we synthesized everything that had been written on integration up to 2022 and into one article. So
awesome. Yeah, we would definitely share that. That sounds great.
Yeah.
Any other questions, or yeah?
In your practice, you talked about S-type, R-type, and racemic. Is there one in particular that you use, or do you use different versions depending on the person's need or what they're seeking? I know one, is it the R-type that's the really trippy one? Or is it vice versa? Is it the S that's the trippy one and the R is just kind of floaty and nice?
I've never worked with them separately. I haven't worked in a place that does Spravato. Have worked with nasal spray, but it was racemic. It was the mix of it was both, and then everything we use in the office is both. It's the mix of the two. So I haven't worked with the molecules separately.
Is it all from the same pharmaceutical company, same manufacturer? Because I know there's like qualitatively, different.
Yeah. I think especially with the oral dissolving ones, those can be really variable. Like, yeah, I mean, even in the same pack, somebody will say like, I swear this one had no ketamine in it, and this one was 5 times more intense. And I don't know. It definitely seems we don't get that with the injectable. We don't get that variety. So I know there's more variables. Like, I don't know, if you had some acid reflux that night or ate something acidic, you might absorb it differently. But or drank something hot or whatever. But it seems like there's too much variability sometimes with this. So we generally get it from the same pharmacy, but we have like a backup one or two in case one of them is out of this happens. Yeah. Even at Walgreens, you get the same medication. You get a generic. If you look at the label, it might come from different places, different times.
Yeah. Well, I mean, I know it's not standardized like ibuprofen. Like one ibuprofen is going to be the same as another, but
it should be. It's supposed to be, but
should be. But yeah, it's
the injectable seems to be. So yeah, I don't know. It doesn't have any. There's no filler in there either. It's pure ketamine in the injectable.
I have a quick question about insurance coverage, and I think you might have mentioned this in the beginning, but I didn't quite get clarity on that. Is this medicine available to folks that have health insurance, or is it typically self-pay only?
Yeah, so the generic ketamine, so Spravato, which was mentioned, is FDA approved, is coverable by insurance, but your insurance is covering that. It seems like it will not cover therapy at the same time, like the two at the same time, which is the problem. So you're there for 2 hours, and that's covered, but no therapist. Or you can pay for the ketamine that's not covered, and then you can use your insurance for the therapy around the process. And so in a ketamine assisted therapy model, the ketamine is actually cheaper than the therapy if you're paying it all out of pocket. So it's about 2/3 of the cost is therapy, because there's a good number of therapy hours that go into it, and 1/3 of the cost is the ketamine. We incorporated as a nonprofit. Sonic Healing Collective didn't say that at the beginning, in part to make it more accessible. And so we have community care fund, and so need-based, we can reduce the cost of of ketamine and or therapy. You know, Bruce can tell you about how funding is for therapy, though it's not generous. So so we try to we also allocate just some of our revenue, like a percentage of our revenues, back to make it more affordable for people too.
That's nice.
We're doing we're self-funding some of that rather than fundraising it, unfortunately.
So what I'm hearing is that if you do have health insurance, you're better off paying for the ketamine, and then the therapy is
Can be covered.
submittable,
Right,
can be covered.
But I think it's just the nose spray. Right, Geoff?
The nasal
It's-
spray can be covered by insurance, right? Yeah.
Not the IV.
Yeah,
Just
that's what
the
she was saying. I think
ketamine.
you're paying for the ketamine and getting your therapy covered by insurance, I think is what you were saying, right?
Yeah. Yeah.
Okay. Thank
And
you.
by the way, we have we just did a build out on our office. We're in Humboldt Park in Chicago.
Oh yeah,
And
I want to hear about this.
We're doing an open house on November 1st, so you can come,
Oh,
come visit
nice.
and see, and we'll be offering a bunch of different like different healing offerings throughout the day.
Giveaways? No.
Yeah,
That
no
was a joke,
ketamine,
sorry.
unfortunately, but other movement.
That's a bad
and,
joke, everybody. I'm sorry. I shouldn't have said that. Okay.
some movement, some music, some art, so different things that we incorporate into our practice. So I didn't mention those, but
Awesome.
yeah, those are all
Yeah.
additional things that we can be incorporating.
Excellent. What's the website so people can find it?
Yep, I can drop it in there, but it's sanahealingcollective.org, SANA.
Excellent.
Let me drop it in, and then under events, you should see our, or under here, I'll just link directly to the office expansion thing, so y'all can sign up if you want to attend.
Yeah. All right, we got it. Well, any other questions or comments about the talk tonight? I know it's a little bit past 8. We really appreciate Geoff not only taking the time to present for us, but everybody who showed up. This has been a great conversation. Like I said, I'm glad sometimes when these go into a more conversational tone, because I think we all learn more as we kind of piggyback off of the knowledge that we had in this room. And I think that's like the importance of presentations like this. So I just want to say thank you. I'm going to turn over to Bruce to say any last words you'd like to say.
Thanks, brother.
He was
short.
Bruce is one of the first people
yeah.
As probably many of you, Bruce was one of the first people I connected with when I was like, who's doing anything interesting with psychedelics in Chicago, and got Bruce's name right away. So.
He's the man. He's the man in a lot of respects. So yeah, glad we could all be here. So yeah, thank you again, and thank you to Cheryl and Urban Apothecary for hosting us. Such a great space. Always happy to be here. And yeah, we'll have a recording. I'll send that off to you guys, and we'll make sure we share any of those links that were in the chat via email and stuff. So yeah, be on the lookout for the next one. We're working on booking the next presentation in a couple months. And yeah, we'll Dr. Tom Roberts, January 15th.
Yeah, January 15th. Actually, Dr. Roberts is the one that got me into my psychedelic academic field, because I presented on my thesis in his class, and then became his understudy and started teaching a class that was a franchise of his psychedelic class at Northern Illinois, which was the first catalog psychedelic class taught at a university. And I just looked it up today. I've been teaching a class on psychedelics since 2003.
Wow. That's awesome. So yeah, January 15th, and yeah, we'll see you at the next one. Thanks again, Geoff, and everybody who came. We had a great time, and yeah.
Yeah, enjoyed it.
Bye, Al.
All right.
All right, Geoff, have a good one.
All right, you guys too.